seen in Massachusetts now, and this my talks on this, is that they got sequential reform. They got the universal coverage first, and that was hard enough. I mean, it's not like every other state's beating Massachusetts to progressive reform. It's the only state that does it. So now what is Massachusetts grappling with? Well, they're grappling with costs. The system is expensive. The health insurance is expensive. So, but that's the bad news. The good news is everybody's at the table now. The employers are at the table, providers are at the table, advocates for the public are at the table, and no other state is seriously considering, as seriously as Massachusetts is, dramatic payment reforms. Because you can, right now, related to insurance, all of it's built on a flawed reimbursement model, which always favors volume over quantity. So in Massachusetts, now that everybody's in on this, and they all have a stake in how this turns out, you are seeing for the first time the doctors in the hospital saying, yes, we're going to have payment system reform, payment delivery reform. And they're going to move away from fee-for-service reimbursement, which exacerbates all the problems. And so they're the only state doing that. So my anticipation is that if we actually pass this reform broadly the way it exists, it'll be step one, stage one, and then we'll have to move to payment reform and delivery reform. And for those who say, well, we need to have all of that simultaneously, I'm a skeptic that that would ever happen. Because that's almost an internal debate that medicine has to have with itself. And it is happening with itself right now. What is the ethos of medicine going to be? Is it going to be more for-profit? Is it going to be more of a humanitarian calling? And that has to happen alongside or after we make the health insurance reform. I just never seen an example of doing all of that at one time. It's just too much for any system to digest. So, am I squeamish about some of the methods that they're using right now? Am I a little skeptical of some of the revenue projections that they're saying? Sure, absolutely. I think a lot of that stuff is speculative. Am I willing to sort of say, I believe it enough to support it? Yep, absolutely. Because I just find that it's been 15 years, 16 years since we've really seriously addressed this. Can they go another 16 years? Because we're not quite 100% confident with the numbers. I mean, I'll be 56. I mean,
I'm 56 now.
Well, I don't want to wait till I'm 56. I don't want to get so pessimistic and cynical that I can't even get up in front of a class anymore and say, yeah, we can do this. So that's not a green endorsement of what we have, but on balance, I would take it over the expense. Thank you very much.
Andrea Miller. Andrea was the Democratic nominee for the U.S. House of Representatives in 2008 for the Virginia 4th District. Ms. Miller is a college professor specializing in information technology and emergency maintenance consultant to the state of Maryland, the Commonwealth of Virginia, and Pennsylvania, in Washington, D.C. She is the Virginia co-chair for Progressive Democrats of America, field organizer and tech team member for PDA National, as well as a member of Virginia Coalition for Guaranteed Healthcare, Richmond Change in Action, and United Virginia. Please welcome Andrea Miller.
With the idea that it's going to be affordable, but you have no numbers. So what we're going to look at now are, what are the numbers based on what they are recommending and what's in the reform Care for All. So what we're going to do is we're going to look at System A and System B. One of the things that I do is I am a lobbyist in Washington. So I frequently go to Washington. I am a citizen lobbyist, meaning nobody is giving me any money. I go because I care and I'm interested. And what we do in Washington is we walk into the offices of the representatives and the senators, and we make our pitch for what we believe is really true health care reform that will save the country money, that will save the citizens money, and that will deliver the health care that everybody needs. Now, Dr. Margaret Flowers is here. She's in the back of the room. Margaret goes, hello. Margaret and I do some lobbying together in Washington. Margaret is with the Physicians for a National Health Plan. So I'm going to do the money, and Margaret's going to do the medicine. All right, so that's how we're going to separate that. All right, now let me go find my little folder here. And, oh, there it is. I'm going to open up 2 spreadsheets. Oh, good, it worked. Doesn't always work. Sometimes it goes, no, this is a little strange. We actually have numbers from what they originally put together in the House bill and the Senate bill. We have no idea what the percentages are going to be because we don't have the final bill. And it's going to go through a complete negotiation, renegotiation process. So the percentages are going to change. Whenever people talk about mandates, it's really critical that we say what a mandate really is. It is the law. By law, you will be required to buy health insurance. There is no law that says you have to have a house to live in. There is no law that says you have to have food to eat. But there will now be a law that says you must purchase for-profit health insurance. All right? That is what these laws do, number one. They produce an individual mandate. The question becomes, what happens to you if you don't buy the insurance? Now, I get really concerned as an African American because of the racial disparities in the prison systems. So I get very concerned about, have they found a whole new way of putting African Americans and Latinos in jail? Because not buying the insurance is going to be a crime. It just depends how big a crime is it. All right? Now, in the House bill, if you didn't buy health insurance for 3 years running, everybody who bought it, the IRS had to tell the government that, yes, these people bought the insurance. So the IRS, the Internal Revenue Service, was reporting every human being covered by an insurance policy. If you didn't buy it, you are now guilty of a federal crime. You didn't pay the IRS. In the Senate bill, there was just going to be a fine. They have modified the tax form. So those of you who do your taxes early, the IRS is getting ready to track this. It's in the new forms. So this is a big deal. Suddenly, the United States government is fronting for a for-profit company. Why don't they just say, you will all buy a Mercedes? I'd like that better. All right, Mercedes has a good reputation. Health insurance does not. Hey, that's got a really bad reputation. Now, I remember when President Obama compared buying health insurance with auto insurance. That's not a reasonable comparison. If you can't afford auto insurance, you can say, you know what, I'm not going to drive. If you can't afford health insurance, are you just supposed to die? Is that it? 45,000 people die each and every year because they cannot afford health care. The package that they want to pass already passed in Massachusetts. They've had experience with it for 3 years. In 2008, 500 people died in Massachusetts because they probably had health insurance, but they couldn't afford the co-pays, so they couldn't go see the doctor. Health insurance and health care are not the same thing. Frankly, they aren't even related. I can actually talk louder than that thing if I want. All right, now, let's go look at some numbers. Got to put my glasses on so I can see. All right, now. If we have one person earning $44,600 a year, all right, under the current plans, and they are, I'm going to make them young.